Basically, what is migraine? We were saying the last time that migraine is a reversible neurological condition. Remember, we were saying that basically what happens when a migraine attacks the brain, the nerves in the brain become insulted. So you end up with like a bad hair day almost inside your head. And that's what a migraine is. The area that we're going to discuss tonight is how it affects the vestibular system. And the vestibular itself is made up of an apparatus in each ear, and they connect to the part of the brain that balances us called vestibular nuclei. So when a migraine insults the brain, the vestibular nuclei, along with other parts of the brain, are insulted. And thus you end up with a vestibular migraine. And vestibular migraine is also known as migraine vestibulopathy. And it's the vestibular nuclei that's insulted. So if I was to say to you that that part of the brain, hypothetically, the vestibular nuclei should be a hand's height above your head when it's working well, that's what normal would look like. But when a migraine hits it hits the brain, it weakens the vestibular nuclei, pushing it into your boots. It's not working, and as a result, you end up with vestibular symptoms, which could be vertigo, dizziness, balance problems, and so forth. And then the migraine abates, and the vestibular system sort of recovers. You come out of that acute phase. But very often people are left with like residual weakness. It doesn't recover to its fullest state. It might be sub-functioning like that. And that's a residual weakness that's left there even when the migraine is gone. And we'll go into that in more detail in a moment. So migraine weakens the vestibular system, and 30% of migraineurs will suffer from this type of migraine. They say that vestibular migraine is the second most common cause of vertigo, but I've put here, in my experience, it's the first most common cause of vertigo. And I really think research is going to prove that in years to come. And there's just two really important points I just need to clarify here, that vertigo is a symptom, not a diagnosis. So if you've ever been told by any professional because of your symptoms that you were diagnosed with vertigo, that would be equivalent to being told if you went into a physio with a pain in your shoulder, they did an assessment and then they gave you a diagnosis of pain. You'd say to them like, sure, I know I've pain, but what's causing it? Same with this, vertigo is only a symptom, not a diagnosis. And this is where an accurate diagnosis is the most important thing, as it is in any case. Until you get the accurate diagnosis of what's causing your symptoms, you can't avail of the treatment at hand. Who gets it? 60% of sufferers report a family history. It affects all ages, and in the proportion of women to men would be 3 to 1. How is it diagnosed? We covered this in more detail in the first talk, where we're explaining that there isn't one single test for diagnosing vestibular migraine. A detailed medical history is taken, and after that, certain tests are done to rule out other causes. And one of those tests is called functional vestibular assessment, and that helps to identify and diagnose vestibular migraine. And those tests involve things like checking the gait pattern. The gait is how the person walks and whether they can tolerate head movements while they're walking. It also assesses balance in detail. It assesses the dynamic visual acuity. That's the ability of somebody to focus on a target and move their head at the same time without falling over or feeling symptomatic. A detailed oculomotor exam is carried out, and that's where the eyes are looked at, because they really are the telling point of what's happening in the vestibular system, both in the ear and in the ears and in the brain. And we use infrared goggles to carry out that test, which is, you can see from the slide there, I was only looking at it earlier, I hadn't noticed it for years, that you can see the eyeball is the size of the screen of the laptop. So it's like cheating, being able to see that. You're able to really identify if there's an abnormality in the vestibular system there. And then the patient is put through different positional tests. And from all that, a diagnosis is reached. And if it's migraine, the person will have reported, if it's migraine, they will have reported possibly 2 types of symptoms. One is pain and the other is aura. And under the aura category are all the other symptoms other than pain, which can include any combination of vertigo, dizziness, disequilibrium, nausea, vomiting, light sensitivity, sound sensitivity, and so forth. And we'll go through aura in detail in a moment, because there were multiple questions about aura, and we'll go through the more commonly seen aura symptoms. When people suffer from migraine, sometimes they might only get head pain, just pain, and that's it. Other times they might get pain and aura, so they might have pain and vertigo, dizziness, disequilibrium, and so forth. But other times they might have no pain, just aura. It's called a pain-free migraine, which almost sounds contradictory. You'd be only short of saying to me, sure, it can't be a migraine if there isn't pain. But you can have a pain-free migraine. Medically, it's called an encephalic or a basilar migraine, where there's no pain, but there are aura symptoms. And when it comes to the pain can be in a variety of areas. People usually think that it can only be the head, like the forehead, the top of the head, or the back, but it can also include the neck with the head, or it might be just the neck by itself, or it might be the temporomandibular joint, which is the jaw joint, or pain might be just in the ear, otalgia, or the pain might just be in the sinuses or somewhere around the face, and any combination of those areas. So if it's in the head, people usually identify that they're possibly suffering from migraine. But if it's in the neck, they don't usually attribute that to being a migraine, especially if they don't have head pain with it. If they only have neck pain, they'll very often think that the pathology is coming from the neck, and they'll come into me saying, I've seen so many physios with having treatment for neck pain, but nothing ever really worked. And lo and behold, why not? Because the problem was that they were migraineurs. The migraine, insult to the brain, was causing neck pain. So what do? You have to treat the migraine and the neck pain goes away. And usually if you have these symptoms, you'll find that your neck pain follows an atypical pattern. If you have a neck pathology and you go to move it suddenly and, you hurt your neck, and then it stays sore for, hours, days, or weeks, whatever, and then you get treatment and it passes off. Whereas the neck pain due to migraine is atypical in the sense that it just waxes and wanes. It comes and goes of its own accord almost. You might just be pottering in the kitchen and lo and behold, you get neck pain. And then you just have a nap for 5 minutes and lo and behold, you wake up and the neck pain is gone. And very often it can be accompanied by other symptoms. So you might have neck pain and feel a bit nauseous or a bit light sensitive. So neck pain coming from migraine, you have to treat the migraine. Same with TMJ, people would come in. It's an area of work that I do, is the management of temporomandibular disorders, and that's people that have pathology in the actual jaw joint. And some people would be self-diagnosed or professionally diagnosed as having TMD problems, would have had multiple treatments for it, including splints and so forth, but yet with no improvement. Why? Because it isn't a TMD problem. It's very probably migraine causing TMD pain here. So they might have no pain here. The pain might only be here. And again, you'd know that from the history. You check their temporomandibular joint. It's functioning perfectly. You diagnose vestibular migraine or migraine if it's peculiar to just pain only. You manage that by going through migraine triggers with them. And lo and behold, they come back and they say, do you know what? I've had no pain in the last month for the first time in 10 years because they have avoided the triggers. Ear pain as well. Sometimes you might only have pain in the ear. And again, people will come in with a history of saying, do you know, I've been checked out multiple times. Everyone has looked into my ear. There's no problem. And why? Again, the pain is coming from migraine. So you have to treat the migraine and the pain goes. And likewise with sinus pain, they did 2 huge studies. One was called SAMS and the other Summit. There were 2,500 people in one and 3,000 in the other. And these were physician-diagnosed sinusitis sufferers. And 90% of both groups that were researched ended up not being sinusitis sufferers, but in fact migraineurs. And again, they would follow a different pattern to the typical sinus, which happens maybe once a year. They might be symptomatic. They might say, oh, every second day I get a sinus infection, or every week I get a sinus infection, and I've had 12 antibiotics now in the last 12 months, and nothing really takes it away. You treat the migraine, you manage the migraine, and the symptoms abate. So pain can be in a variety of places. Likewise, when it comes to aura, we had multiple questions about aura. We touched on it in the last talk, so I was just going to go into it in more detail here. And I think if we went through all the aura symptoms, we would be here until maybe January, because the list is endless. But I'm going to go through the most commonly seen ones. And if you have other symptoms, very possibly they could be aura as well, as daft as they might seem to you. Vertigo would be the illusionary spinning of the environment. So lo and behold, you're sitting there and you would swear an oath that the walls were moving around you. Dizziness would be inside the head, where the walls aren't moving, but inside your head, there's that dizziness or that lightheadedness, or it could be a spinning sensation inside the head, or a feeling like, whoa, I could pass out here, but it's all inside the head. And very often migraineurs suffer from this muzzy head feeling. They feel like they have a fog inside their brain, or that they're feeling like a bit spaced out, or that they've only cotton wool between their ears. I know we all feel like that at times, but this is peculiar to migraine aura, having that just nothing but cotton wool between your 2 ears. Or you might feel disequilibrium. That's that feeling of unsteadiness, or a feeling as though you're on a boat and the ground is almost coming up to you a little bit and then dipping away from you, and you're having to readjust your balance in a very, obvious way, not just spontaneously. Spatial disorientation is where you have that disconnection with your environment. You just don't feel you're connected to it. It's almost like an out-of-body experience. And a lot of people report where they stop at the traffic lights, and when they brake and stop, the car stops, but they feel like they keep moving. Or they're stopped at the lights and the car next to them starts moving. So they start jamming on their brakes, thinking that it's their car is moving, when in fact it's the other car. So it's that total mismatch between where you are and what's happening with the environment. Intolerance of busy environments, very commonly seen amongst vestibular migraineurs, and especially during migraine aura. So you might go off on your Saturday, be happy shopping, and then you're inside in the shop and you just feel the whole thing becoming overwhelming. Suddenly you start to be very aware of the bright lights, the shiny floor, all the products, the people, and so forth. And again, that can happen if there is a residual vestibular weakness, like we were saying, if this thing hasn't fully recalibrated, but it can be heightened as part of aura. You might have a feeling as though your eyes are catching up with your head, that when you go to turn, and the faster you move, the more aware of it you are. So you might go to turn your head like that and feel like as though your eyes are catching up. And if you turn and turn back, you almost feel like you meet your eyes on the way back. So again, it's that mismatch. And that is the truth. Your eyes are catching up with your head. And that's in keeping with a vestibular weakness. Again, this thing being down like here. Reduced cognitive function, you might also feel where you're just not up to the game of working in the manner that usually this task would be done very quick, not a bother, but suddenly it's really challenging you to carry out a simple task. Or you might just be sort of have that feeling of confusion where you're working and it's just like everything becomes just overloaded. You just feel, or you might even be at home getting the dinner ready. The kids are shouting. The husband's saying, is the dinner ready? You're like, whoa, hang on a sec, lads. Just that whole confusion state. Or forgetfulness is another one where you might go down to the bedroom to get something and lo and behold, you can't remember what you came for. And that could happen repeatedly, especially during a migraine aura. Nausea and vomiting, often seen as well. And photophobia would be incredible. Light sensitivity. Now, migraineurs are sensory sensitive anyway. They see light brighter, they hear sounds louder, they smell smells in a more pungent, strong way. But during a migraine episode, all that is heightened. So the lights appear brighter, the sound appears louder. And again, that's part of migraine aura. You're not going mad. You're not being a whinge bag. You're not being intolerant. You are actually suffering to a greater degree. Likewise, motion sensitivity, where you would feel that if you were a passenger in a car, this is less seen by adults because we usually drive our own car. But if you were a passenger in a car during a migraine episode, you might feel, oh, that, you know, this drive hasn't done me any good, that I feel quite motion sensitive. You might have sinusitis symptoms, not just pain, but also tenderness. You might find, oh, definitely my sinuses are at me, when in fact it's the migraine. Or you might even be more congested. Or again, with sinusitis, you can have that awful fatigue and washed out feeling, again, part of it. And mood alterations are part of migraine aura. It isn't just physical, but you get that emotional draining where you're going fine. And next thing, when the migraine aura hits, the wind has gone out of your sails. You're like, whatever happened to me? And you can become quite flat in yourself for no apparent reason. Again, part of migraine aura. Tinnitus, which I'll go into in more detail later on, again, can be part of the migraine aura. You also have benign tinnitus, and a lot of people suffer from tinnitus. But if it's part of migraine aura, you will get increased symptoms during the migraine period. So if you have no tinnitus and suddenly you start to hear tinnitus inside your head, and then it goes away again, and it's peculiar to when you have other migraine symptoms like maybe head pain or nausea or light sensitivity, then the tinnitus is part of the migraine aura. Or if you are a migraine or tinnitus sufferer already, you may suffer increased tinnitus during the migraine phase as well. Some people report excessive visual dependence. So this is because we balance with three systems: our vision, our vestibular system in the ears and brain, and our joint receptors. And if I was just to say hypothetically that each of those should be doing 1/3 of the work in keeping us balanced, well, during a vestibular migraine, when your vestibular system is being weakened, that 1/3 isn't doing its part. So you're down 1/3, so you're left with the other two parts, which is the vision and the joint receptors. The joint receptors can only do what they're meant to do. They can't work harder, but vision can. And that's where people will become more dependent on their vision during a vestibular migraine. So they may report reduced balance in dark environments. So they might be absolutely wrecked. They get home, they get out of the car, they go, and the lighting isn't as good from the car to the door. And they'd say, geez, I'd swear enough that I could have fallen coming in there. They're in a migraine state and they really are needing vision to keep them balanced. And some people suffer hemiplegia. That's a weakness down one side of the body as a result of migraine aura. And that can be, short-lived and fleeting, or it can be more protracted. Or some people might suffer body jerking responses as well. If in doubt, rule it out. Don't ever think, okay, I have a weakness down one side, I bet it's part of migraine aura. If in doubt, rule it out. We cannot risk a permanent problem if something else is going on here. So you have to go and get it checked out. And if a stroke is ruled out, then, or any other pathology that could be causing it, then possibly it could have been the part of your migraine aura. Also, speech can be affected when it comes to migraine problems. And there's three main speech pathologies that occur. One is aphasia. That's where you lose the ability to articulate words, to come out with words, to come up with words. So you might want to say, I would like to take the dog for a walk, but you end up going, duh, duh, duh. And I've seen people like this, where they literally suffer aphasia. They cannot come out with the words. Dysphagia is where there's a partial loss of language. So instead of saying something with, you know, a string of words, they'd be long pauses and shorter sentences. So again, instead of saying, I'd like to take the dog for a walk, it might be dog walk, sort of that. Or dysarthria is where the articulation of words is challenged, again, because the vestibular migraine is insulting that part of the brain that controls speech. So with dysarthria, the muscles aren't working as they should. Speak with like a slurred speech. There'll be a slurred speech. Again, they're all those speech abnormalities, would be not just peculiar to migraine aura, but also could be significant of some serious pathology in the brain. So that would always need to be checked out medically. If in doubt, rule it out. Don't risk it. There were multiple questions about symptoms. One of them was, can you get different symptoms with each episode? Absolutely. One time you might just get pain, another time you might get pain with vertigo, dizziness, disequilibrium. The next time you might get no pain and you might have nausea, vomiting, light sensitivity. It might vary every time. Is there a comorbidity with other vestibular disorders? Absolutely. A huge comorbidity that I would see people as vestibular migraineurs and they'll come back another time with another vestibular problem. And I remember that was part of our training, being told that, which I thought was quite strange, because vestibular migraine is peculiar to the brain, but yet vestibular migraineurs will very often come back with other pathologies, maybe in their inner ear. It is hidden. It is difficult to explain to family and colleagues, and it is very frustrating. I've just written here, yes, in order to help others understand what you're suffering, because it's a nightmare when you're suffering from any type of migraine. It's hidden, nobody can see it. There are expectations of you, you're not rising to the game, and there's lack of understanding. So two things, Deirdre and I were saying, like, for people to share this video, and the other one that colleagues and family of sufferers would understand it better. But really, the Migraine Association of Ireland is going to be your best bet. If they log into the website, they have a brilliant website to go down through all the different things that migraine sufferers suffer from. So could you have another vestibular disorder? There were multiple questions about this. There are lots and lots of different vestibular disorders. I've narrowed it down to the more commonly seen ones. And the first one would be what's called residual vestibular dysfunction. And remember, I was saying a while ago that the vestibular nuclei hypothetically should be like a hand's height above your head. And when you get migraine, it gets pushed into your boots. And then the migraine abates and you start to recover, but you don't make a full and complete recovery. There's that residual feeling that you're just not fully right. That's what residual vestibular dysfunction is, that residual weakness that's in the vestibular system, after the migraine has abated. And usually this includes symptoms like dizziness and unsteadiness when you're walking or moving your head. So what's the instinctive thing to do? Avoid moving, to move, unblock almost robotically, because the last thing you want to do is bring on dizziness. And it's actually the opposite you need to do. And I'll go through that in treatment in a moment. The treatment for that is vestibular rehab, where it'll involve a lot of movement to get the vestibular system from here back up to here. When it comes to residual vestibular hypofunction, this is the same as dysfunction, but it's due to a problem in the inner ear. It's a residual weakness that's there after the inner ear insult has abated. Here, benign proximal positional vertigo is a very commonly seen vestibular problem, and they say that it's the most common vestibular disorder. But again, I've put an exclamation mark there, because I believe it's the second most common, vestibular migraine being the first. And I think research will show this in not too distant future, I hope. In this case, this is a problem of the inner ear, because we've 6 canals in our ears, 3 in each ear. And inside in those apparatuses in our inner ear, there are little bony particles in a cup. And those bony particles roll out of the cup and end up in a tube where they shouldn't be. And the history for this, and that's why the history taking to discern if somebody's a vestibular migrainer or not, helped hugely, because in the case of BPPV sufferers, pardon me, the sufferer will report positional vertigo. It's a vertigo that will come on after they get into a new position, 2 seconds later. So it's not while they're moving, because remember I was saying with vestibular migraine, it's when you move, it's like, whoa, you feel your eyes catch up with your head. With this one, you lie down and then 1-2 seconds, whoa, then it comes on. So there's that delayed response. And this very specifically lasts for 10 seconds and then stops. And once you don't change position, you don't get any other symptoms. The treatment for this would be very different. You need to put those particles from the tube back into the cup. A maneuver, once the correct canal is identified, the maneuver itself only takes about 2 minutes. But it's really important with this. There are loads of YouTube videos about how to do canalith repositioning therapy, but you could be doing the wrong maneuver for the wrong canals, because there are 6 canals, 3 in each ear, and there are multiple options for each of those, details of which I won't go into now. But I've seen so many people use the wrong technique, and instead of putting particles in, they've dislodged particles out of other canals unnecessarily. Meniere's disease is another disease that's very commonly seen. It's again, it's a problem in the inner ear, and we have a fluid that usually drains repeatedly in the inner ear. But in the case of Meniere's, this fluid doesn't drain, it builds up. And then you get this burst of a flow, and the person will get, again from the history, they'll be able to tell you, I get this acute vertigo, and it's violent vertigo where the walls are violently spinning. They can't even lift their head off the bed or off the couch. They just have to stay very still with their eyes closed for several hours, 3 to 6 hours. They also get tinnitus, increased tinnitus, very intense. Oral fullness, where they feel this awful pressure in their ear, and deafness, which can be transient, but accumulatively people end up having severe hearing deficits down the line. So it's always accompanied by those 4 in the advanced stages. And I'll be talking to you in a minute about CERC, which is a medication that's very often given to vestibular migraineurs and should never be prescribed for vestibular migraineurs. The one time it might be of benefit is in the case of management of Meniere's disease. But again, the jury is out as to whether it is of any benefit. I'd usually recommend patients trial it for 6 to 12 months to discern its benefit or lack of, because the research is quite mixed on it. 50% of migraineurs, of Meniere sufferers, are also migraineurs. Talk about having an unlucky hand dealt to you. Bad enough to be a Meniere sufferer, but then 50% are also migraineurs. The treatment for this again, is vestibular rehab, which I'll go through in a minute, and a low sodium diet. Vestibular neuritis is where a virus tracks along the vestibular nerve, and it can be viral or bacterial. It's usually as a result of a herpes simplex virus, which would be the common cold sore that we'd get, or a chest infection, or even just a head cold, and it tracks along. And in this case, the person will get, it's very specific, they'll get this acute vertigo for 24 hours, which lessens in the second day and begins to abate in the third day. So they have to crawl to the loo day 1, they can be helped to the loo day 2, and they can get their day 3 if they just hold the wall. It's a 3-day process. Again, the management of it is to recalibrate the vestibular system using vestibular rehabilitation therapy. And labyrinthitis would be the same as neuronitis, the last one I said, but the other branch of the nerve called the cochlear nerve that helps us to hear also gets involved. So along with vertigo for 3 days, they also get hearing loss. And it's very important that they're started on steroids very quickly to minimize any permanent hearing loss. And again, a GP would implement that. Bilateral peripheral vestibular hypofunction. Bilateral means both sides. Peripheral is in the inner ear. Vestibular hypofunction. It's where the 2 sides, the apparatus in each ear, are not working. And usually this happens as a result of exposure to autotoxic drugs like gentamicin. And all the mycins can make you susceptible to suffering from this. So that's why, you know, the use of antibiotics really needs to be taken seriously, not just at lib. And the same with opioids for painkillers. What the autotoxic drugs, auto means ear and toxic, you know what toxic is, it basically kills the functioning of the nerve in that area. And the person ends up, because it's affecting both ears, you don't get that mismatch between the 2 sides. So they don't really get vertigo and dizziness. They more get balance problems, and hearing can be affected. And the balance problems, because the vestibular system is so compromised, they're much worse in the dark. And they would have difficulty seeing things as they're walking along a street. If they had to watch and read a sign on a shop or on a street, they'd have to stop and look, because if they were walking, the sign would be bobbing up and down. Again, the treatment for it is vestibular rehab. Maldebarkment, several people were asking me about at the last talk. And this is basically sickness of disembarkment. It's the illusion of movement after getting off a mode of transport. It could be a boat, a train, or even an aeroplane. And it's the feeling of movement when stationary. The patient will always feel worse lying down. Do you remember I was saying a while ago that after a vestibular, during or after a vestibular migraine, if you move your head, you'll feel worse. It's the opposite with this one. They're worse when lying and stationary. So when they're lying in bed, they feel like they're constantly swaying, and they feel better if they sit up, better again if they stand, better again if they move. Whereas people with vestibular weakness as a result of migraine will be the opposite. They'll be at their best lying down and more symptomatic when they sit, stand, or walk. So the opposite to other vestibular conditions. Again, treated with vestibular rehab. Presbystasis is the natural aging process of the vestibular system, usually seen to begin in the late 70s. And by the time we hit our 80s, it usually starts to creep in quite, significantly. And that's why it's really, really important that people, as we mature, that we don't allow our vestibular system to weaken prematurely. We need to keep it at the top of its game all the time, because the stronger it is entering our late 70s and 80s, the less presbystasis will push it down and weaken it. With presbystasis, people end up with balance problems and dizziness. Again, the treatment is vestibular rehab, which involves a lot of movement, and I'll go through that in a minute. And it is so true with this. If you don't use it, you lose it. Like when we're younger and if we've a flu and we stay in bed for a couple of days, we get up and we could be back playing football within a week or two. If we're older and we stay in bed for a couple of days because of a flu, and we get up and we don't move much because we find that when we move, we're quite unsteady and a bit dizzy. The less we move, the less we'll improve. So if we don't use it, we lose it. So it's really important to try and progress, always maintaining as much mobility as you can. And if you find that this is applicable to you and you find that, yes, actually, I can relate to that. I remember I used to be able to do this before, but I couldn't do that now because my balance wouldn't let me. Well, don't give in to it. Don't stop doing it, but have it assessed and start a program that will allow you get back to it, to the optimal state. So instead of avoiding things that challenge you, you need to challenge it back. Acoustic neuroma, or it's also known as a vestibular schwannoma, it's a non-cancerous tumor on the vestibular cochlear nerve, the nerve that supports balance and hearing in the inner ear. And the patient will suffer from hearing loss, tinnitus, dizziness, and loss of balance. It's a non-cancerous. Of all my patients, I've only ever had one patient that required surgery for it. Usually it's watch and wait. But radiation therapy or surgery is necessary if it's rapidly growing, because it can cause damage then just because it gets bigger and bigger and starts compressing on other areas. Cervicogenic dizziness. This is dizziness due to neck pathology. And you can imagine, like when I was saying there, that this can be with or without neck pain. And there's no true spinning, there's no vertigo, but there's a dizziness. And that dizziness is brought on by moving the head. But remember I was saying a while ago that with vestibular migraine, if you move your head, it can make you dizzy because your eyes are trying to catch up with your head. So how can you differentiate cervicogenic dizziness from vestibular migraine weakness dizziness? The way you do it is when you move your head like that, you're moving your vestibular system and your neck. So it could be either. So what you need to do is you need to keep the vestibular system stationary and move the body under a fixed vestibular system. And if by moving the body left and right like that, I'm moving the neck. And if I report, oh, I'm quite dizzy now when you do that, and when you turn the other way, oh yeah, I'm quite dizzy as well, then that's cervicogenic dizziness. By moving the neck, it's causing dizziness. The treatment for that is to mobilize the neck. It would need to be assessed, mobilized, and the person would need to be given a home exercise program to keep those joints mobile. And the time I usually see this would be after road traffic accidents or traumas, a fall from a height, or a belt of a hurley or something like that. And also they need vestibular rehabilitation therapy exercises different to these ones. Concussion, it can be a to the head in sports, road traffic accidents, or a fall. And it's basically where, you know, the way like the brain is like a mushy thing inside a solid a cage of bone. And what happens with concussion is the head gets a belt and that mushy brain bangs against the inside of the skull, and that traumatizes the brain. These 4 areas of symptoms that patients would suffer from. Some people might have emotional, sorry, I'm just pushing this on. They might have emotional, pardon me, emotional changes. That's where after suffering a concussion, they might end up feeling quite sad or quite irritable, more irritable, or they might have cognitive problems where their ability to pay attention to tasks is grossly compromised, or they might have problems with memory or working out. You know, a student might say, I was well able for maths before and now I can hardly add 1 and 1. or they might have somatic symptoms, which would be physical ones like visual problems, dizziness, unsteadiness, headache, nausea, all the sort of vestibular type ones. And fourthly would be sleep alterations. They might have difficulty falling asleep or fragmented sleep, or find that they wake up too early. The treatment for this, the most important treatment for concussion, is rest. It is so important to rest, and to rest fully, to rest from work, to rest from school, to rest from watching TV, rest from reading, rest from talking, just to rest, to allow that swelling in the brain to just all calm down. And then once the time is right, vestibular rehabilitation therapy can be implemented. But also brain gem, we need to get the brain back working again. So it's that cognitive focus on crosswords, and a gentle exercise program to get the person progressively being more active. The thing about after a concussion, people are more prone to migraine. So people that were never migraine sufferers beforehand can suffer from migraine after a concussion, or people that did have a history of migraine will end up suffering possibly to a greater degree from migraine after suffering a concussion. Not every case. So if you've just had a concussion, don't be thinking, oh no, what am I heading into? You could be the exception to the rule. Persistent postural perceptual dizziness. This is something that there were multiple questions about. And this is where, instead of full recovery after vestibular insult, so the vestibular system gets insulted, and in the case of the vestibular nuclei, it gets pushed into the boots, and then the migraine abates, and the vestibular low, that's a weakness. But in this case, instead of complete recovery, the brain stays at this high alert state, reacting as if it's constantly in danger. And the sufferer has this constant feeling of motion and dizziness and unsteadiness when they're up and around. And the severity can fluctuate during any day. Anxiety then usually kicks in around things that trigger the symptoms. So they'd be benign situations like walking becomes highly provocative. So you know that walking down along a street isn't a high risk category if you're walking down the street here in Middleton, say. But the vestibular system sets off alarms and sirens in this high alert state, making the person feel this intense anxiety in this high alert state, and that's 3PD. These symptoms are present 24/7 to varying degrees of severity, usually only abating when the person is lying down and sleeping, or if they're fully supported. In order to qualify for this diagnosis, you have to have been symptomatic for more than 3 months. The residual symptoms that are there, that constant feeling of motion or dizziness or unsteadiness when you're moving around, get worse when you become upright. So you'd be at your best lying down, and then when you sit up, you begin to feel it. And then when you stand up, you feel it to a greater degree. And then when you move, you feel it to a greater degree again. You'd also feel worse when you're exposed to movement, especially complex visual patterns. So if you were to walk into a hotel that would have zigzag patterns on the carpet, it's like, whoa, hang on a sec here now. Or busy shops like Pennies on a Saturday would be your worstest nightmare. And also the third time that you would be more aware of symptoms would be when you're performing precision tasks like reading or scrolling down on your phone. You'd have to turn away and scroll and look again, or even using the computer. The treatment for this, again, is vestibular rehab, but also exposure therapy. Exposure therapy means exposing yourself to the challenging environment. So if going into a grocery store is extremely challenging for you, and if you give up doing it and you say, I'm not going to go in, well, then you will never allow your system to be exposed to the stimulus in order to get it used to it, and you'll forever want to avoid that shop. Whereas what you need to do is you need to go in a systematic, progressively manner. So you might go in for 5 minutes, first of all, but use a trolley, and you might feel, whoa, the symptoms are coming on. So you go back out, you sit on a bench, and then you go back in and you do that for another 5 minutes, and you gradually expose yourself to it, and you increase the time from 5 to 10 to 15 minutes, and then you get rid of the trolley and you try and go in without a trolley and so forth. So that's all exposure therapy. If you avoid the situation, you'll never get used to it. In the majority of cases, vestibular rehab and exposure therapy is enough to conquer 3PD. But in persistent and resistant cases, the other two legs of the tripod, we call it, need to be implemented. One is cognitive behavioral therapy, abbreviated as CBT, and that's where a cognitive behavioral therapist would retrain your thought process to minimize your brain. And if implementing that second leg of the stool didn't suffice, then the use of SSRIs or SNRIs would be implemented. And your GP would, on the, the recommendation, we do up a report, would prescribe these. And these are antidepressant, anti-anxiety type medication. But you're not depressed. You're not taking them because you're depressed. You're not taking them because you're suffering from anxiety, because they wouldn't be areas that we would be trained in diagnosing. You're taking them to calm down the bells, the whistles, the sirens, and they're taken for a period, not forever. And I know we're all sort of a bit like, oh no, I'd hate to go on those sort of drugs. We're all like that. But it's a case of using a crutch while your leg is broken until it gets, and then you've no crutch. The same with this. You take the medication to calm down the sirens just for that period while you do your vestibular exercises, while you try to go into the shop and expose yourself. And as you feel your system is tolerating all these things, you then start weaning off the drugs, and the results are brilliant. So there is always, people with 3PD very often can become hopeless, and you don't need to be. I promise you, you do have a really, really good chance of making a full and complete recovery. It's just the time frame is what's difficult to quantify, because it varies with everyone. When it comes to, how come that isn't moving? There, orthostatic hypo or hypertension. This is where people report, they say, I get dizzy when I get up. And I would always check, and this isn't where you have raised or lowered blood pressure as per just checking it in a sitting position. This is blood pressure regulation. I've put regulation in bold there. It's poor blood pressure regulation. So it's the body's ability to alter the blood pressure when you go from one position, like lying, to sitting, to standing. Usually our blood pressure system should be able to regulate that, so we're asymptomatic. But if when you go from lying to sitting to standing, you're like, whoa, and you feel really, really unsteady for a period and you have to hold on to something, you need to have this checked. And it's not a case of just checking the blood pressure. Like I said, you have to lie down for 10 minutes, and after 10 minutes have your blood pressure checked, and then immediately stand up, have your blood pressure checked again, and within 2 minutes have it checked a third time. And it's the alteration of either the top or the bottom number, the systolic or diastolic, of more than 20 millimeters, accompanied by symptoms where you get up and you're saying, oh yeah, I can feel it there now, I'm quite dizzy. It's the reading on the blood pressure monitor accompanied by the symptoms diagnoses this problem. So it may not have been picked up if you only had your blood pressure checked in sitting by the nurse or doctor. And the treatment to transition in phases, so you go from lying to sitting and leave your blood pressure regulate. Then you go for a period, then you go from sitting to standing, and just hold on to something and wait to allow your blood pressure to regulate, and then you can start moving. Make sure to take plenty of fluids because dehydration can make this worse. And you need an increased salt amount intake to regulate this, because you can imagine when you take in salt, it'll hold on to more water, so that'll help regulate it. And sometimes drugs are needed. Temporomandibular disorders, we touched on it earlier, that people come in with pain on the side of their face, thinking that it's as a result of a TM joint problem, where the jaw joint with its muscles and bones aren't functioning as they should. And there can be pain anywhere on the side of the head, misdiagnosed as TMD, when in fact it can be migraine. And this is with or without clicking. So just because you have a clicking jaw doesn't mean you have TMD, or that the clicking jaw is the source of the pain. Again, the jaw joint has to be assessed. It's ruled in or ruled out. If the symptoms are as a result, if the pain here is as a result of migraine, treat the migraine. If it's as a result of diagnosis, is the most important thing. You could be going off putting mouth guards in and everything, getting no relief, when in fact it's the migraine needs to be treated. So how do we treat vestibular migraine? There's two ways. One is we need to stop the migraines from occurring in the first place by avoiding migraine triggers. So the other way I was saying, just peculiar to the vestibular nuclei, the trigger comes along and it insults the brain. So one, we need to stop the triggers. And two, we need to recalibrate the vestibular system to allow it to make a full and complete recovery. But this is after the migraine episode abates. So if you're a migraine sufferer and you suffer a migraine during the migraine, you definitely don't do any vestibular rehab. One, you rest. Two, just to try and slow everything down. Two, you try and identify what brought this on. 3 o'clock in the afternoon and I haven't eaten since 6 o'clock this morning. I haven't drank any water today. Eat if you're hungry, drink if you're dehydrated. Address what has triggered it, and then allow your system to recover. And then the following day, because you'd be a bit washed out the day of a migraine, so give yourself that day off. But the following day, maybe you could get going on the vestibular rehab. The triggers, similar to any migraine, for vestibular migraine, the same triggers: emotional, environmental, lifestyle, hormonal, diet, and now we have COVID to add to it since recently. When it comes to emotional, it's at the top of the list, because stress and anxiety are the #1 causes of all types of migraine. It can, depression can also be a trigger, and poor efficacy for management of headaches. If you just don't get your act together, if you don't listen to the advice that the Migraine Association is giving you, saying you need to avoid these triggers, you need to exercise, you need to, poor management of it, that's another one. And really what's important is to have that balanced lifestyle, where you have that balanced mind, body, and spirit. And stress is part of all of our lives, but we have two choices when it comes to stress. We can either allow that stress to come in on top of us, flare up a migraine, we'll feel awful, and the condition we're getting stressed about hasn't been helped by our response. Or the other response is to say, okay, I'm going to get totally stressed over this thing now. I have two choices. I can either leave it frazzle me, or I can not let it in. And we have an incredible power to do that, to say, I'm not going to let this frazzle me. And as a result, you minimize the chance of a migraine from occurring, and the event is going to get resolved anyway, or it's going to continue anyway, whatever it might be. You getting stressed isn't going to change it. So each of us need to be gentle on ourselves. We need to look after ourselves, and we also need to look after each other. And to be aware as well that we don't need to be doing, and achieving all the time. We need some time to just be. And that is invaluable for migraineurs, if they can just slow down and be. Their emotional came up. Environmental, another significant trigger. Light sensitivity. So this is where if you're exposed to bright lights, it can be detrimental, or bright sunlight. So to use polarized sunglasses or a peaked cap if the sun is very bright, or especially if it's low in the sky, like at the moment, if we'll ever see sun again, to have a peaked cap that'll come down to try and keep it away from your eyes. Migraine glasses, again, if you're exposed to being on the computer a lot as well, and to avoid fluorescent lighting. That's why we changed all our lights here from fluorescent to LED, just because it'll, again, just minimize it a little bit better. Smell sensitivity, so to try and avoid strong smells. Sound sensitivity, try and avoid it. And again, like I was saying, you know, sometimes we can avoid loud sounds, and as migraineurs, we'll be more sensory sensitive. We'll hear sounds louder, we'll see light brighter and so forth. But during an episode, they're all heightened. So the sound will appear louder. So you'll be saying to them at home, Mother Divine, could you not make any more noise filling the dishwasher? That you feel like they're almost banging the plates together, when in fact, it's just the normal filling of it, but you're hearing it in a heightened manner. And you might be saying, did you ever turn down that noise? Again, you're hearing it in a heightened manner. No, you're not a nag, you're not a whinger. You are suffering as a vestibular migrainer from being sensory sensitive by nature, and then having increased sensitivity because you're having a migraine at the time. So put in earplugs and head off, leave them fill the dishwasher, leave them listen to the loud TV or whatever, and go off and have some quiet time yourself. Weather changes as well, something we can't change. Increased atmospheric pressure can have a hugely negative impact. Migraineurs would always say to me, I feel like a barometer. I know when the weather is changing. That increased pressure, and lo and behold, they get a migraine. Another part would be lifestyle. And it's really important to maintain a regular sleep schedule. Lack of sleep or oversleeping can cause problems. So it's very important to try and go to bed at roughly the same time. Now, not to be fanatical about it, because that in itself would be stressful, saying, it's 10:05, I'm supposed to be in bed at 10. That's pure stress. But I'm just saying, like, not to go to bed at 10 one night and at 2 a.m. the following night, but roughly have a regular sleep schedule, and not oversleep. Very often migraineurs, when they're just about to enjoy a nice Saturday morning lie in, lo and behold, they will wake with a migraine. Why? Because they've overslept. It's called a Saturday morning headache. So a routine, you may not suffer from that, in which case that's great. Enjoy your Saturday morning lie in. But if you do, you may realize that actually I won't be able to enjoy lie in because I'll suffer for the day with the migraine, and it isn't worth it. Routine about everything. Migraineurs do best if they're in a routine, and that's routinely eating, exercising, and sleeping. To try and do everything routinely. And we're such creatures of habit. So like exercise doesn't come easy to any of us, mea culpa. But if you get into the habit of doing things in a routine, that you go for that walk every morning, you get up 1 hour earlier every morning and you go for that walk, and you say to yourself, I'm going to do this every day for the next 20 or 30 days. I promise you it'll become a routine and you will just keep going. Likewise, we can get out of routine so quickly as well. So try and develop that routine and avoid nicotine. It's an all nasty. If you find that you can't kick it fully, just be aware of every cigarette you have to minimize them. lifestyle with regard to posture. There were loads of questions about this the last time. And it is really important to adopt a good posture, because if we slouch, imagine if we're watching TV and we're slouched back on the couch in a slouched position. When we slouch, if I move this for a second, when we slouch back like that, our spine curves. But in order to see what's happening, we have to lift our head. So if I straighten my spine, I'm actually having my neck like this all the time. So that's having a hugely distorted posture for long periods of time. So to avoid slouching, and the same with avoid having your head forwards or down. So especially now during COVID, this was a huge problem for people when they're on the computer all the time, socializing and working, because on a computer, and I found myself doing it today as I was preparing these slides, I found myself going like this, looking at it like that. And that's where it's really important not to have yourself like this poked forwards, or likewise with the phone, not to have your phone here where you're looking down at it all the time. I find when I'm driving to work in the morning, all these kids are lined up for the buses, and they're all lined up and they're all like this with their heads down. And again, that's hugely provocative of migraines. So to bring your phone up to you and to adopt a good posture, always try and have your head directly above your shoulders and have your back supported against the back of the chair, and to move your whole body forwards and backwards, not just leaving your body where it is and sticking your head forwards like that. And just as a note, this was the only place I could put it in. If you're sitting on a bus or a train, always try and sit in the direction you're traveling in, because if you sit the opposite way, again, that can trigger a migraine. That whole mismatch of the fact that your body's moving that way, but the environment is moving differently. Exercise, lots of questions about this. It is really important to exercise, and it has been proven that low levels of activity relate to high frequency of migraine. So if you don't exercise, you have a higher risk of migraines. If you do exercise, you have a lower risk. So they're inversely proportional. So it's really important to exercise. The amount and the intensity of exercise varies with every individual. So it's peculiar to each individual. I'd usually encourage people, the majority of people, to get out and go for a 1-hour walk every day. Because when we exercise, we release endorphins and enkephalins, which are those feel-good hormones. And if you can imagine stress and anxiety almost like being a fire that burns up inside us, causing that migraine in our head. The release of endorphins and enkephalins when we exercise is like putting a bucket of water on a fire, and it dampens down. So even though you might be so tired and so fatigued when you get home from work or whatever, or frazzled from the kids all day, when somebody comes in to rescue you, just say, I'm out of here, put on your hat, your coat. In Ireland, don't wait for the weather. I've heard so many weather excuses this week, it's unbelievable. I've told everyone to go off and get their rain gear and head out, hail, rain or snow, to head out and get the exercise every day to release those endorphins and enkephalins. In the snow, obviously, and ice, it can be dangerous. So don't walk on the roads, but walk through the fields, or go into a large shopping centre if busy environments don't bother you, and walk up and down, or there are car parks, just so that you can get out and get exercise. Do you want to hear the bad news? Some suffer exercise-induced migraine. There actually is an exercise-induced migraine. People that when they exercise, they end up getting a migraine. In that case, they have to curtail, not abandon their exercise, but to curtail their exercise to a tolerable level, to the level that doesn't cause migraine. So if they go for a 45-minute run, they end up getting a migraine, and they want to train for a marathon, they want to increase it, they may not be able to. If they go for a 30-minute run, they don't get a migraine. They may need to just limit it to 30 minutes. It's all about managing it. We're all individuals. Hormonal, lots of questions about this, not my area of expertise, but a 2-second a couple of comments on it. There is a huge connection between hormones and migraine, especially when estrogen levels are varying. So estrogen has a significant part to play in it. So if people have no estrogen, exogenous estrogen, which would be estrogen taken in from outside the body, needs to be avoided. It needs to be a progesterone only. And people will be prone to suffering from migraines or increased migraine frequency and severity during puberty, during menopause. I would say the majority of my patients would be menopausal women that would be suffering from vestibular migraine. Likewise, during the menstrual cycle at different points. And pregnancy is the frequency during pregnancy, but other people, when they get pregnant, they have no migraines for that period. So it can vary. With regard to diet, like I said in the January talk, there are volumes of books written about diet and migraine, but really important points would be regular meals and always eat at least every 8 hours. Of course, we do that during the day, but I'm talking about at nighttime, and that's why it's always important to have a snack before you go to bed, because if you're going to be in bed for 8 hours, you need to eat something before you get into bed, something light like biscuits and a glass of milk or something, and to avoid being hypoglycemic in the morning, which would be the low blood sugar levels, which in itself can trigger a migraine, and avoid dehydration. So just like eating the wrong foods are bad, eating no food or not drinking water they're two hugely commonly seen triggers of migraine. So avoid dehydration. Make sure you get at least 3 pints of water every day. And you can keep a diary. There's 2 types of diaries that can be kept, because it's good to keep a diary to try and see what triggers your migraines, especially from a dietary perspective. The Migraine Association have a fabulous paper copy one. That's the picture there, the guy with the pen, and it's a brilliant one. There's also an app called Migraine Buddy, which is a paying app, and it can be a little bit demanding. If you're into apps and you're happy to do lots of techie inputting, then it's for you. If you're not, the Migraine Association paper one would be a fabulous option. When it comes to diet, again, instead of going through all the dietary things, I'm just going to say that there's 6 most commonly seen dietary triggers. We call them the 6 C's: caffeine, cheese, red wine, a claret, citrus, chocolate, and MSG, Chinese. They're the most commonly seen diet triggers. When it comes to COVID-19 and migraine, there is a significant connection between COVID-19 and head pain. And when I say COVID-19, I'm talking about both the virus and the vaccine. The headaches with regard to the virus is one of the most common symptoms of COVID-19. Headaches are. And 20% of COVID sufferers develop persistent chronic headaches. And this is even higher in persons with a history of migraine. COVID-19 can also trigger migraines for the first time. So if you've been a migraine sufferer and you have found that since suffering from COVID, you're getting more headaches or persistent chronic type headaches, well, then that very probably is due to COVID-19. Or if you've never had migraine and now you're suffering from it, that's a high possibility as well. Same with the vaccine. It hasn't been shown to trigger migraine, but it has been shown that headaches are more frequent, last longer, and were more intense in people with a history of migraine. So the research up until now has very much focused on COVID and headaches, not just peculiar to migraine. So there's lots of research coming down the line, lots of it necessary. And further research is focusing on identifying treatments as well, which is great. Threshold, you don't just like end up being exposed to one trigger and end up having a migraine. You don't just have your cup of coffee and end up with a migraine necessarily. Migraine triggers are cumulative. So you might get stressed about something, not sleep the best, skip breakfast, grab a coffee to keep yourself going, and boom, you've hit the migraine. So you want to try and slip in under that radar and not reach the accumulative state. So when it comes to treatment, we referred to vestibular rehab a couple of times there. And this is basically systematic exercise-based program to recalibrate the vestibular system. Remember I was saying at the beginning of the talk where the vestibular system gets weakened, the migraine abates, but the system doesn't fully recover. And what vestibular rehab does is it provokes recalibration so the vestibular system can fully recalibrate and get back to normal pre-migraine state. This is a very much an evidence-based practice. Huge amount of research has gone into it in the States and in Europe as well now in recent times. And instinctively, vestibular migraineurs are inclined to avoid head movements. And who wouldn't? Here you've suffered from dizziness, the migraine is gone, you go to move your head and you feel dizzy. So you're like, whoa. The truth is, moving your head won't prevent or provoke an episode, but what it will do is is in fact exactly what you need to be doing. And I always explain to patients that there's two types of dizziness, a bad and a good. A bad dizziness is when you're there at work, doing your work, and suddenly, boom, you start to feel dizzy. That's a migraine insulting your brain, causing the dizziness and weakening your system, to be avoided by avoiding migraine triggers. A good dizziness, on the other hand, is when the migraine is gone. Once you don't move, you're fine. But when you move your head, whoa, you're dizzy. That's a good dizziness. That's the brain trying to recalibrate it. Vestibular rehab exercises involve a lot of head movements because by moving, it's given a chance to recalibrate. It'd be the same as breathlessness. There's two types of breathlessness, a bad and a good. A bad breathlessness would be if you were there at your desk on the computer and you started to get breathless for no reason at all. A bad breathlessness. A good breathlessness is when you go for a jog and you start to get breathless. That's a good breathlessness because that's strengthening your cardiovascular system. Vestibular exercises and head movements are strengthening your vestibular system. So vestibular migraine, they need to move. So what does VRT entail? It entails head and eye movements. So it might involve looking at a target, moving your head a lot, or it might involve moving your head and your eyes, but it always involves two things. One is where your eyes are focusing, and two is where your head is moving to varying degrees. It also involves balance training, and with balance, you have to challenge it. If you just limit yourself to doing what you can do safely without challenging yourself, it will never improve. But if you find standing on one leg a challenge and you're having to really work on it to stay on the one leg, I'm not standing on one leg now, I'm actually sitting still. But if you're finding that you're having to work, that's brilliant. That's your system trying to work out how to keep you balanced. So if you're like this week 1, you'd be like this week 2. And by week 3, you'd be solid, standing on one leg. Your reactions would still be occurring, but they're fine-tuned and they're not elaborate anymore. And that's what challenging the system does. It strengthens it. And that's peculiar to all ages, from very young that have had vestibular insults right up to very mature ages. And exposure therapy, like I was saying earlier, where you expose yourself to the challenging environments, if it's going into a shop or if it's looking at challenging things on TV, it might be, pardon me, it could be that you find it very difficult to watch race cars, like Formula 1 races on the TV or something like that. Again, you'd expose yourself. in a graduated way. And that's part of vestibular rehab. We would give patients a list of videos to work through, from easy ones to more difficult ones. So you would end up having like Times Square, where there's people and lights and cars and, oh my God, so busy, or a Venetian village in Las Vegas, where you can imagine like the flashing and the ding dong and the noise and the everything. And you expose yourself by looking at these videos on a large screen, and the bigger the screen, the better. You could do it on your phone, but it's better if you do it on larger screens. So a laptop is better than a phone, but a big smart TV is better again. And you sit there and you expose yourself to it, and you feel yourself being stirred up, at which point you pause the video, you go off, you do whatever you want to do. You can rest or be active until the symptoms of stirring up settle down, which could take 2 seconds or 2 hours. And then you come back, you unpause, you expose yourself to the stimulant again. And again, you get stirred up, you pause it. And bit by bit, you keep exposing yourself to that stimulant in a very progressive, controlled manner. And by exposing yourself over days and weeks to it, you develop an ability to unpause, play the video, and you can watch the entire thing without having to pause it at all, because your system has got used to it. That's exposure therapy. Clarification of some of the VRT questions involved. VRT, is it tailor-made to each individual? Absolutely. It isn't one fits all. The home exercise program varies, because you've even seen there, whether it's balance or moving your head or watching a video, it's peculiar to each individual and the diagnosis. Should the home exercise program provoke dizziness? Absolutely. It should provoke, it can provoke dizziness. It doesn't always. But if by moving your head you feel dizzy, that's great. That's the vestibular system recalibrating itself. The crux is that the increased dizziness shouldn't last for longer than 20 minutes after stopping. And it should never provoke nausea. Not that you've done any damage by exposing yourself to it, but if the dizziness lasts for longer than 20 minutes, you'll get nothing done with your day. You'd be saying, what? Was I going down to your one for a mother divine? I'm more dizzy now than I ever was. So it is important to expose yourself to it, but to a level that you can tolerate. So you might just manage to have symptoms for 20 minutes, but then you need them to be gone, because the kids need to be collected or work needs to be done or whatever, and never provoke nausea. Once you tolerate the exercises, that means you then progress. And that's where by doing them, there's no provoking of symptoms, or if they are, they're very slight and they stop within 2 seconds of stopping. And one person was asking us, should she recalibrate at the fairground? Would it be good to go and challenge herself at the fairground? To be honest, that definitely would be too much initially. But you might want to progress to that. If your family love going on roller coaster holidays, well, then certainly you may need to progress to that, and that will be part of your program. More clarification, can VRT cure migraine? No, no, no. VRT simply, vestibular rehab, simply recalibrates the vestibular system between episodes. It takes it from here to here. And you're trained in how to do that, and whatever your vestibular physio teaches you, keep all that information, because if you were to get another episode, which migraineurs do, a week, a month, a year, or 5 years after you've been discharged from vestibular rehab, you don't need to go back for more treatment. You know how to do it. You identify the trigger and avoid it. Rest, leave yourself recover, as in leave the migraine abate, and then get going on the exercises. Can VRT exercises provoke migraine symptoms? No, they won't provoke or prevent a migraine. They'll simply recalibrate it between episodes. And one patient was asking a question. She was saying, I started vestibular rehab and I was fine for the first 2 weeks, but then I got dizziness. That was a migraine. That was a spontaneous episode of dizziness. and that was a migraine in the morning, day one. And at lunchtime, you ended up getting dizzy. People would ask me, so was that the exercises bringing on that dizziness? No, 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 you don't get delayed dizziness from doing the exercises. That would be like getting delayed breathlessness from going for a jog at 6 o'clock and getting breathless at 3 o'clock in the afternoon. No, no, you get dizziness during and might last for a bit afterwards. But any spontaneous dizziness that comes on, that would be due to a migraine. How can you do exercises if you're constantly dizzy? Somebody dizzy, the source of that dizziness needs to be identified. So if it's due to this sort of this dysfunction here where it hasn't recalibrated, that dizziness needs you to do the exercises because that'll recalibrate it. If the dizziness is because you feel constantly that you're getting repeated vestibular migraines, because constantly for some people might mean every day I get it for an hour, but that wouldn't be constant. So you can do it outside of the migraine period. Or if you're feeling constantly dizzy because of 3PD, well, then again, you get on with it. The vestibular exercises are going to recalibrate it, and thus inversely, proportionally, will minimize the dizziness. Should I use a wobble board in order to help me? No, wobble boards are used to, you know what a wobble board is? It's a board with like either a ball or it might have a concave support underneath it, or convex support underneath it. So the board is wobbly and you stand on it. That won't recalibrate the vestibular system. That will retrain the joint receptors how to function. So that's great in the use after, say, an ankle injury. But in order to retrain balance that is needed, you would stand on a cushion. You can get the formal medical cushion, or you just simply use a couch base that you would sit on, put that on the ground, and that's how you recalibrate the system. With regard to drugs, avoid vestibular suppressants. They should never be used in the management of migraine, and limit stimulant to symptomatic relief of nausea. Never use anything to take away the dizziness. Rest, leave it at 8, and then get going on your exercises. With regard to migraine medication, not my area of expertise, but just in summary, there's 2 types: acute, which is prescribed for people that have symptoms for less than 15 days a month, or preventative if you are suffering from migraine more than 15 days a month. When it comes to tinnitus, this can be quite stressful for a lot of people. And sometimes people might just be suffering from benign tinnitus, they have it anyway, but it'll increase if it's during a migraine, if it's part of the migraine aura. And it can be a ringing, a buzzing, a humming in one ear or both ears. It usually feels like it's like inside the head. And people can experience anxiety and significant depression as a result of it. Can be part of migraine and fluctuate with the episodes. And they feel that it's due to a variety of reasons. It can be due to age-related hearing loss because your hearing isn't as good. You can be more aware of it, or it can be as a result of an ear injury or a problem with a circulatory system or part of migraine aura. The time it needs to be investigated is if it's localized to one ear, if it's pulsatile in nature, if it's accompanied by asymmetrical hearing loss. So say you have tinnitus in the right ear and you have hearing loss and it's pulsatile, like a pulse, like in nature. And if there are any other neurological area for it, how to cope with it, think positively. Don't give it headspace. Avoid stress. Like I was saying, stress is just the #1 killer of so many aspects that weaken us. Avoid loud noise exposure. So to use earplugs if you are going to a concert or if you're going to a wedding. Keep occupied. Don't sleep during the day. Don't rush around unnecessarily. You could try masking the noise and either just like putting on a radio in the kitchen, or you can get one of these things. It's like a noise box, and it has a timer, and you can put on different sounds like running water or birds or so forth, my kids say, Mom, somebody's wet the bed. If you put that beside them, and the running water one, but so it's nice to mask it if your tinnitus is just doing your head in. Don't drink too much alcohol, try not to worry, evaluate effects of food and drink, because very often, you know, migraine triggers like caffeine and alcohol also exacerbate tinnitus. Some people need to attend a self-help group, and that's where Chimes, the national charity, is a great help. Talk to a friend or develop a hobby. What help is available? You can get a hearing aid if the tinnitus is up, which dampens out the tinnitus. A tinnitus masker like the white noise maker that I showed you there, or likewise you can just download apps on your phone. Relaxation therapy, counselling, medication can sometimes be used, and surgery in extreme cases. But the Irish Tinnitus Association at chimes.ie are the people to contact about that. Sleep tips, I've only 2 more things to say. I just saw the time. Mother divine, I can't believe I've kept you all night. I'm sure nobody's still on. But 2 more things. This and one really important thing at the end. With regard to sleep, sleep is as important as breathing, drinking water and eating food. It is so important. So if you don't have a good sleep pattern, try to develop it, because it'll make such a difference. It can have such a positive impact on your migraines. Things that will help: don't have any caffeine, minimize alcohol and sugary things. Have a routine, like I was saying, regular sleep, regular meal times, and don't do any high exertion exercise 2 hours before bed. Take time to relax and be in a relaxed environment. So when the day is done, sort of take a breath, breathe in, breathe out, and say, oh, my day is done, and now I'm going to relax before I go to bed. So you have that transition period between the manicness of day and sleep. So you can just slow everything down. Don't have any screens in the bedroom. Sleep in darkness, and don't stay awake if you're, don't stay in bed if you're awake. Don't be lying there going, oh, clock watching, another hour, another. Get up, go to the loo, have a sip of water, lie back down and start again. Avoid technology, which would be like blue light tablets and laptops and stuff, at least 1 to 2 hours before bed. Read a book, a happy one. Don't be reading something like How to Conquer the World, Being Progressive at Work. No, like a happy, slow down one. Make lists if you're like me, and they say to me that they're going to put a pen and paper in my coffin because I'm such a list person. But it is great, you know, if you have a lot of things in your on your mind that particular day, if you just leave a pen and a piece of paper beside the bed, and if you think of something, you just write it down and say, okay, that's tomorrow's job. It's like there, it can wait for the morning, so you don't have to worry about it. You can sleep. Foods for sleep: milk, chicken, turkey, pumpkin seeds. They're recommended before you sleep. Don't clock watch, like I said. A daily walk, moderate exertion, at least 30 minutes in daylight, and to look around and be active like that when you're walking. 30 minutes minimum. I would say 60 minutes if at all possible. And mindfulness, just to calm yourself down. Mindfulness in whatever way that might take its form in you, whether it's a meditation or through prayer, but just to be calm your system. When it comes to, and this is really important, reasonable accommodations for students of all ages, and the reasonable accommodations are given to migraine sufferers, not based on their diagnosis, but based on their need. And there is a significant need for migraine sufferers to be helped. And these reasonable accommodations are to allow migraine sufferers to play the game on a level sports field with their peers who are not migraine sufferers. This isn't cheating the educational system. This is allowing sufferers to play not a game of football on an uphill slope, but on a level field like everyone else. And they qualify for reasonable accommodations in a couple of forms. One is with regard to exam assistance, and that would be extra time. At the moment, if I'm correct, and you can check with the Department of Education, it was always 5 minutes extra time for every 30 minutes of state exams. And so in a 3-hour exam, which would be the typical state exam, you'd get an extra 30 minutes. And you can use that time to take breaks, where you have to like notify the supervisor, the clock is stopped, you can like have read the English essays, decide which one, stop the clock, sit, have something to eat, think of your essay, and just slow everything down. You can eat during it, you can drink during it, you can be accommodated in a non-sunny, because you don't want to be in an exam hall where lo and behold the sun is shining right into your eyes. You can request a shaded, quiet room. So you would be accommodated in a room separate to the big hall where 300 other pupils are. And all that environment just allows you the possibility of minimizing a migraine from occurring. Also, to use the laptop, that'll avoid crouch writing postures, because you know, if you're like bent over like that with a pen and paper, whereas with the laptop you can adopt a good posture that I was talking about earlier, minimizing a migraine. You also avoid tension writing and the pattern lines, because sometimes the exam papers can have significantly lined sheets of paper that they give you, and that could be too much, or it might be stark white paper. Also, you can apply for DARE, and that's a case-on-case dependent. So our vestibular report would be supporting paperwork. For that, we would make the recommendations for what you need to apply for reasonable accommodations. 3 top tips to conclude. Avoid migraine triggers, avoid vestibular suppressants, because they will just delay recovery, and move. To move is really important. If you want to find out more information about vestibular rehab, you can visit our website, where there are multiple blogs about different types of vestibular conditions, or you can look at the different content that has been put up on Facebook, Instagram, or LinkedIn.